So there's an increasing number of individuals on dialysis. Um, you know, adults are living longer and often have complex medical problems and are opting to do dialysis. So we're going to talk about hemodialysis, peritoneal dialysis. There is a lack of donated organs, and even some individuals are not interested in an organ transplant, but are willing to do dialysis. So there's a big need for nurses, and you would be have excellent, strong nursing skills, because a lot of these patients can turn critical very quickly. So you really have frequent assessments and really strong, excellent nursing skills if you are interested working with the renal population in a dialysis center. So like I mentioned, peritoneal dialysis and hemodialysis. Peritoneal dialysis is performed at home by the client, and then hemodialysis can be performed in a dialysis center or at home. It's usually a client would start dialysis when their GFR is less than 15, or they're having significant life-threatening complications. So for example, maybe a client's GFR is 17 or 18, but they're having seizures or cardiac changes, so a client, or severe fluid volume overload. So a client at that time would start dialysis. The nephrologist does make that determination. So the principles of both types of dialysis, diffusion and osmosis. So diffusion, the movement of solutes from an area of greater concentration to an area of lesser concentration, and osmosis, the movement of fluid, again from an area of lesser concentration to an area of greater concentration. So that's really what we're talking about: blood being filtered, waste products being removed, excess fluid being removed. If you hear the term ultrafiltration, that does mean water and fluid removal. So with peritoneal dialysis, a catheter, a Tenkoff catheter, would be surgically placed in the abdomen. It does have a cuff. It is sutured in, and it would be in the peritoneum, and that would be placed by a general surgeon. It can be used pretty immediately after placement. They do like to wait like a week or 2 weeks, but it can be used sooner. So this catheter would be in place lifelong. This would kind of be the client's lifeline, because they no longer have adequate kidney function, and your kidneys are necessary for maintaining life. So they really would have to protect this catheter, prevent any infection. If there was a superficial skin infection right around the outside, that would be fairly minor. But if there was a peritonitis, an infection within the peritoneum in the fluid, that would be very serious, and it could actually prevent the client from being able to do their dialysis. So that's a serious complication that we'll talk about. Clients can not take a tub bath with a PD catheter. They cannot swim in a live body of water. So those are some things that clients weigh into their decision making, whether peritoneal dialysis is for them. So there's 3 phases: the inflow, the dwell, and the drain. These 3 are termed a cycle. There's 2 different ways to do peritoneal dialysis. So there's an automated peritoneal dialysis and an ambulatory peritoneal dialysis. So we'll talk about each of those. The osmotic agent is dextrose. So the peritoneal dialysis fluid has different percentages of dextrose. The higher the percentage, the more fluid is removed. So a client may have 3 different percentages, and depending on their weight or their symptoms, how short of breath they are, how many pounds of fluid they gained, that would determine which percentage glucose bag they used. So the automated peritoneal dialysis, the client has a machine, and they do have to basically go to bed at a certain time and get hooked up to their machine, and they do several cycles while they're sleeping. And some clients may do one during the day, some clients not at all, just at nighttime. So that's one option for peritoneal dialysis, as the automated cycler. Continuous ambulatory peritoneal dialysis, this would happen 4 times during the day. The client would instill fluid into their peritoneum, and then they would disconnect the tubing and they would go about their day for several hours with this fluid in their peritoneum, and then they would drain their catheter and instill more fluid, and again repeat that. The fluid would be in their peritoneum for a few hours for the dwell time. During this time, you have just diffusion and osmosis occurring, and all those waste products are going to be drained. So clients can work, they can hike, they can, be ambulatory. They're not locked in a chair for 4 hours at a set time, a certain days of the week. But this is a daily procedure. A lot of patients on peritoneal dialysis, because they're doing the exchanges multiple times a day, it does mimic your normal kidney function closer than some of the other options. So clients do tend to feel better. They have less dietary restrictions. So this is an example of a nighttime cycler machine. So PD complications, I mentioned the superficial exit site infection, that would be minor. Peritonitis is serious. So symptoms of peritonitis would be cloudy drainage. So that would be abnormal. The drainage, after you do the dwell time and you drain, everything's by gravity. It really should look clear yellow, almost like urine. So if it's cloudy, that would be abnormal. The client may have abdominal pain, they may have a fever, and again, that is their lifeline. That's very serious. So they would require antibiotic therapy. It might require hospitalization, IV antibiotic therapy. They might not be able to do PD until they get the infection under control. Hernia, because there is quite a bit of volume being administered, so clients are at risk for hernias, low back pain. There is a risk of bleeding. So that first exchange, there might be some pink tinge drainage, but after that, there really should not be any bleeding, clots, anything like that. That would be abnormal. You would teach your patient to report that. Because the fluid that is in the peritoneum, it can push up on the diaphragm. Clients can have atelectasis and be at risk for pulmonary complications, and there is a big protein loss with this type of dialysis, so these clients need a high protein diet. So hemodialysis actually removes a client's blood, filters it through an artificial machine, and then returns their blood. So that hemodialysis machine acts like your kidney. So clients do need vascular access to have this done. So a fistula or graft, or a temporary catheter, or a tunneled catheter. So this would be a fistula, where you have the client's own artery and vein. Again, this is a conversation that you should have with a client when they're at stage 3 or so of chronic kidney disease, because CKD is progressive, they will eventually need dialysis. You want to give them all the information, the pros, the cons of each option, let them decide when they're feeling well, and then have this placed a year or more before they actually need it. Because you want it to be mature before you use it. So a lot of clients with chronic kidney disease may have had severe hypertension for a number of years or diabetes, so they may have other complications to their vascular system. So it may not be possible to find a good spot for a fistula. So clients may have a graft, and this is a synthetic tube basically that would connect the artery and the vein. This is not first choice, but again, maybe the only choice for that client. This is another hemodialysis graft that requires a synthetic graft that is tunneled underneath the skin. So something else that you may see. So you're worried about impaired blood flow, so you always want to assess the client's vascular status. Aneurysms are another risk. You want to have, again, this is the client's lifeline. This is how they are staying alive. So you want to have them protect that fistula or graft at all times. So no lab work, no blood pressure, very meticulous infection prevention, hand washing, they really shouldn't be touching the area. No IVs in that arm. So these are examples of some temporary catheters. So this would be a tunneled catheter where there's a cuff, it's sutured, it's tunneled underneath the skin. There is an increased risk for infection, and it's never the first choice for a client to have a catheter over a fistula or a graft, but again, they may not have the vascular access, or they may not have the time because it takes months for the fistula or graft to really be able to be used. So you can see this catheter is not tunneled, and there's a high risk for bleeding. Clients really cannot be discharged to home with a temporary catheter. And another example of a long-term cuffed HD catheter. So I know many of you were able to go to the dialysis center at Saratoga. I'm sure not all of you, and it was, if your patient was a renal patient at Glens Falls, so some of you may have cared for a dialysis patient and others may not have. The actual dialysis filters are very large filters. They act as the semi-permeable membrane where the osmosis and diffusion occur. So this slide I want you to really star and pay attention to. So this would be the nursing care for a client before they have hemodialysis, or things that we would teach our patient to do before hemodialysis. So you really want to assess a weight. That's super important. That's how you're going to know how much fluid needs to be taken off your client when they're on hemodialysis. So a weight is going to be the best indicator of fluid status. You're also going to assess their vital signs. That's going to be important, and then throughout the dialysis treatment, they're going to have blood pressure, pulse monitored every 30 to 60 minutes. So I didn't mention it, but these clients also have frequent blood sampling because you need to know what their numbers are. You need to know what their potassium is. That's going to be an important piece of their hemodialysis. To access the fistula or graft, they're going to have two large bore needles, one that's going to remove the blood and the other that's going to return the blood. When I say large bore, I mean 14 or 16 gauge needles. Those are pretty big needles. The tubing is primed with saline. After the treatment is done, the tubing is flushed with saline. So every attempt to return the client's blood is made, because remember, these patients don't have any extra blood. They're anemic. They're at risk for bleeding, so we want to try to minimize any of the blood loss. Pressure dressing after, super important, because they are at an increased risk for bleeding. So one day working on a medical floor, I had a renal patient come back from dialysis. I assessed him, got vitals, got him all tucked in. He was totally wiped out, exhausted, wanted to take a nap. I had checked his dressing, and thankfully someone had gone in to remove his lunch tray, and he was sleeping, and his pressure dressing came off and he had blood all over. Thank God he was okay and we were able to apply pressure and stop the bleeding. But you always want to frequently check on your client when they come back from dialysis. Your patient that's going home, you would want to teach them to keep that pressure dressing on and keep an eye on it for 12 to 24 hours after. So I'll let you just take a look at this again, an overview of the hemodialysis. Most clients, if they are at a in-center dialysis, it's 3 days a week, and it would be 3 to 4 hour treatment. So these would be set times, so you are Tuesday, Thursday, Saturday, 7 a.m. to 10 or 11 a.m. There's really very limited flexibility. There's waiting lists to get into different dialysis centers and different days and different times. Patients dialyze late in the evening because there's so many patients that need dialysis and only so many dialysis chairs and machines. So they have 2 different shifts, and they have several slots from early morning, 6 or 7 a.m. all the way until, late in the evening. Some clients opt to do home hemodialysis, so you do have to have a trained support person. You have to be willing to insert needles or have your trained support person be able to insert these large needles. You would need to have room in your house for this large hemodialysis machine. You would need to have internet connection because you are being monitored. Your settings, your alarms, your vital signs are all being monitored. Some clients will do a short treatment daily, so maybe 6 evenings a week they're doing a few hours. And these patients, the more you do dialysis, the better you feel. There's nocturnal hemodialysis as well. So it's kind of individualized based on your patient's preference. This is an example of a home hemodialysis machine. The newer models are a tiny bit smaller, but you get a good idea of all the equipment that you need. Some clients are not interested in having medical equipment in their home. Some clients prefer that and don't want to go in center. So hemodialysis complications. Hypotension is a big one. So you will always see a client dialyzed for hemodialysis in a recliner or a bed so that you can change their position rapidly if they become hypotensive. If a client does become hypotensive or complain of muscle cramping, perhaps you took too much fluid off too fast. So next time you would slow that rate. You might have to actually replace some saline because again it was too much fluid removed. Clients again are at risk for blood loss because of the platelet defect, the nature of hemodialysis, the pressure dressing, the use of the large bore needles. There is a risk of hepatitis, not as much hepatitis B because of vaccination, but hepatitis C, it is a blood-borne pathogen, and there's very strict infection control measures, but there's still a risk. Water regulation by the health department is also a big deal with hemodialysis centers. So continuous renal replacement therapy is not going to be on your test. I do want you to just be familiar with it in case you come across it. It is used for treating acute kidney injury. It's a very temporary, it's a 24-hour, very slow hemodialysis. It's extremely expensive, and it's done, very short term for an unstable patient that would be unable to tolerate the stress of having hemodialysis, because it does place a lot of cardiovascular stress on the client. I just kind of threw this in as an extra, and I'll show you a picture of this when we do our Collaborate session, but hopefully you'll see lots of new treatments for end-stage renal disease coming out. This has a long ways to go. It's basically a mini dialysis machine that a client would wear on a belt, and it is kind of like an artificial kidney, but it looks very large and not very easy to perform your daily activities. But hopefully, again, we'll see some really exciting new treatments for end-stage renal disease. So that's it for this PowerPoint.